Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Hi, Jeff.
Hi, Christine. Been a long time, it seems.
I know, and we are at the tail end of 2025. Crazy.
It's unbelievable, and it's nice to see you. I mean, there's been a lot going on in fall months, and I got to comment, your social media presence is quite impressive. I'm enjoying it a lot.
I have help.
Very cool.
No, it's exciting. It's a whole new area. Admittedly, I feel a bit old, but it is what it is, and I think that there's a whole cohort of Canadian doctors that now are embracing the concept of direct to our patients, which I think is really important.
I think you're right. I think it's very cool. So kudos to you.
Thank you. So we are approaching holiday season, a lot of hoopla and a lot of stress, which is my somewhat elegant way of segueing into the topic for today, which you are definitely the thought leader in the studio in, hypertension.
I don't know about a thought leader, but I was one of the co-authors of the guidelines, but I'm not sure about a thought leader, but thank you.
A big cheese. So I just saw actually a patient today, and I don't think I did the right thing. A 69-year-old professor has had a hard go. You know, that person that you think is just going to cross over that cardiometabolic line at some point. And he came into me, to be fair, doesn't love the doctor's office, even though I tend to be very charming, just doesn't like going to the doctor's office. His blood pressure was registering 144. I'm just looking at the value right now, over 88. And it's been creeping up over time. And then I got this wonderful summary that you made. So what I did is I sent him home and said, it's Amazon Prime Cyber Day. Buy yourself a reasonably priced blood pressure cuff. Take your readings for 2 weeks and let's talk. But what am I going to talk to him about when he comes back?
Well, it's true. You're right. Okay, so what we did recently is we wanted to simplify the hypertension guidelines. So we published the Hypertension Canada, published the primary care hypertension guidelines. And I mean, on the committee were a cohort of experts, some family doctors, general internists, cardiologists, nephrologists, etc. And the reason we did it is we really wanted to simplify the guidelines, and we did. So we chose an evidence-based number. We can talk about it. And we made it really easy. It's all about 130 over 80. So 130 over the 80 is the target for everyone.
My blood pressure just went up. I don't think I managed people well today.
And you obviously read the guidelines because you sent your patient home. So you did the right thing. I mean, they come over at 144 over 88. They're considered hypertensive. But as the guideline defines, you want to confirm it. So first you did it on an automated office blood pressure machine where you got 3 readings. They were seated in a room by themselves with their feet planted on the floor, not crossed, arm at like heart level. And you got 144 over 88. So you did the correct thing. You sent them home, told them to buy a home blood pressure monitor. Honestly, I mean, I'll suggest brand because Omron is probably still the best. And they can go on Amazon and have their Omron delivered tomorrow. All sorts of bronze, silver, platinum. It doesn't matter. Depends what kind of things you want on it. And exactly as you said, you're going to send them home to do 2 weeks of readings. And the way we suggested is do 3 days a week, take 2 readings, maybe at different time of day. So 1 in the morning, 1 in the evening, 2 readings, average them, and do that for 6 readings. So 2 weeks. So they will come back after that with 6 double readings of which they've averaged so that you can get a sense of whether your high office reading is confirmed at home or do they truly have white coat hypertension, which is a different thing. In the majority of cases, you'll probably confirm it is what it is. And as the new guidelines say, if you're over 130 over 80, it's considered high. We commence treatment if it's confirmed at over 140, not over 80, sorry, over 140. If you don't have risk, if you have risk, we commence you at 130 once we've confirmed it.
Okay. So I suspect this lovely professor who's super stressed, and now I'm super stressed because I'm worried about him, is going to come back with some high readings. I also told him to do it every day. Sorry if you're listening. But he's a prof, he's into that. And we all have patients that kind of come
That's okay. He can do it every day. Won't hurt him. All right.
with Excel spreadsheets. So one tip that I am going to insert my 2 cents with is confiscate people's iPhones. Because the number of times I come back in the office with your patients are attached to the blood pressure machine and they're checking their iPhones, that's not going to help. But let's go back to my patient, has actually a history of a pulmonary embolus just recently on Eliquis. So I suspect that I'm going to be treating him.
Yeah, you're likely going to be treating him. I mean, the pulmonary embolus itself isn't considered a cardiovascular risk, but you're going to treat him because he's over 140 in any case. He doesn't have any other issues. He's not pre-diabetic. He doesn't have CKD. He doesn't have anything else.
No official cardiac risk factors.
All right, so we'll see. I mean, we've seen it, and 130 over 80 is chosen because we see that cardiovascular risk starts to rise at actually 115. And once you get over 130, that risk is 50 to 100% higher of cardiovascular risk. So you really want to treat them. Lower is better. The lower you are, the longer you live, but at the expense of side effects as we get really low. And we can talk about sprint because some people have said, why did you choose 130 when sprint had 120? And we can briefly address that because we get that asked a lot. So yes, sprint had 120, but a few things. The average achieved in sprint was actually 121 and a bit. 60% of people got below 120. But remember, in a clinical trial, blood pressure is 5 to 10 points lower. So in fact, if you look at the sprint trial, it's really is equivalent to about 130, and that's why we chose 130.
I didn't know that actually. Wow.
Yeah, so 130 has the perfect balance of benefit, safety, side effects, and the evidence suggests that 130 is a really good number, especially if you look at what happened in sprint. But I think what you said is probably one of the most important things is you have to confirm it. Like you have to confirm it at home or with a 24-hour ambulatory blood pressure machine. You have to confirm it.
Okay, so this gentleman's going to come back to me after I've increased his high blood pressure because I'm making him take it once a day or twice a day. What am I going to start with?
Okay, so we've confirmed it's not white coat. He's the real shebang. And like I said, 75% of them will be the real shebang. This is another thing that was changed. We're now saying start with a low dose combination. So low dose combination of ACE-ARB, calcium channel blocker like amlodipine, or ACE-ARB diuretic. And start with a low dose. Like an example would be, and we're looking for drugs that are inexpensive and widely available. In the guidelines, we give a lot of examples. I mean, low dose combos that we think about all the time, telmisartan, amlodipine, and then all the diuretic combinations. And we'll talk about diuretics because that's also changed. We have prindopril and amlodipine as another option, probably not as inexpensive, but it is generic now. But you want to start with a 2-drug combination in low dose. So let's say I was going to start with telmisartan, amlodipine. I'd probably start with half of a 80/5 tablet and then see them again in a month or two. And if I had to go to a full one, I would go to a full one. And then the next add-on would be the drug that I hadn't used. So if it's ACE-ARB, amlodipine, I would add a diuretic or the other way around.
And you mentioned how quickly after? 6 weeks, 8 weeks?
Well, I mean, I would see them 1 to 2 months later to see how they're doing. I mean, it's changed a lot because we would never think of starting combinations for hypertension. And now that's what the guidelines are recommending. The other thing that was shocking to all of us in the evidence, there's been a big push in the last 3 years to go to longer acting diuretics and avoid hydrochlorothiazide because it's short acting. So we've been told use indapamide or chlorothalidone. But the recent evidence does not actually support that. And they're saying you certainly can use hydrochlorothiazide. Remember, not ideal for patients with skin cancer risk. And truly, my favorite diuretic now is probably indapamide. I mean, it's easy. I don't have to split it.
Mhm.
I mean, we now have hydrochlorothiazide 12.5, which is great.
Mhm.
We don't have lower doses of chlorothalidone. And if we're going to start 12.5, we typically have to cut it in quarters. So I'll either use a combo with one of them, or I'll use indapamide on its own as a diuretic to get them started.
So different target, simplified target, 130/80.
For everyone.
You have them confirm in whatever way you choose. Start with combination therapy, early callback, adjust therapy as needed. That is simpler than before.
No, it has made it simple. And we've said, okay, so you're starting with low dose single combination therapy, full dose combination therapy. If that doesn't work, you the other drugs, so amlodipine or diuretic. And if that doesn't work, the fourth step would be to add spironolactone and monitor potassium. But I mean, you'll probably see changes in that algorithm because we're getting some new blood pressure meds in the next year that have very significant lowering potential. So we'll see if the guidelines adopt it and how they change.
So maybe we'll be back flat hashtag holiday season 2026 and do another update with a big cheese.
And then the other thing I want to mention are the white coats. What do you do with them? Because that's always so. White coat means their numbers at home are always averaging under 130. They come into your office and they're 140, 150. And if they're dependable, they're doing it at home and they have true white coat hypertension without risk, you do not need to treat them. The conversion rate of the white coats is interesting. It's higher than I thought, but about 5 to 10% a year. They say over 10 years on average, about a third. So watch them because they will convert. Some of them will convert, but if they have no risk and they're truly white coat, you do not have to treat them.
Another stat that was quoted is that I think any patient over 60, 2/3
Yeah,
have
that's
hypertension.
crazy, eh?
That's crazy.
Yeah, I mean, 20% of all adults, so 20% of all Canadians over 18, but 60% of 65-year-olds, we generally say 80% of 80-year-olds have hypertension. So that's something, you're right, 2/3 of our seniors have hypertension.
It's much more than I thought. So we're approaching the holiday season. Everybody comes into my office in January. Oh, give me a little bit of leeway. It was a fancy-filled, gluttonous Christmas or Hanukkah or whatever holiday is celebrated. And the reality is that we need to treat people early. But you provided a simple overview. So thank you for making the rest of this month simpler for me.
Thank you. And that was the point. We really wanted to simplify it so that all of us can deal with it more easily because it's certainly the
Yeah,
most common chronic illness that we deal with in primary care.
absolutely. So happy holidays.
Happy holidays to everyone. And thank you, Christine.
We're really excited for an exciting 2026 ahead with a lot of hot topics.
All right. Happy holidays, everybody.
Take care.
See you later.